We're live from the McGarry Communications Center right here on the campus of East Stroudsburg University of Pennsylvania. I'd like to welcome you to Brain Tumor Talk Worldwide Radio Show. This is a show like few others on the airwaves or on the internet. This is a show dedicated to brain tumors and brain cancers. This is a place where stories of survival are going to be shared. We discuss brain tumor issues, new treatment options, and bring not only awareness but action, not just words. We're going to feature worldwide organizations and events that are working towards making a difference. Now, this is also a special place to support all those fighting brain tumors and brain cancers, admire and recognize the survivors, honor those who have been taken, and spread a message of hope. My name's Rick Franzo. I'm a two-time brain tumor survivor. I have the privilege of being your host every Friday evening for Brain Tumor Talk. We're going to be playing some great music, as you just heard here, and we cut Sammy Hagar off, which I can't believe that we had to do that to the Red Rocker, but you don't want to miss any of the next hour. The following is my opinion and those of my guests and their stories, and not those of 90.3 WESS. As always, the content of this show is for informational purposes only and never constitutes medical advice. Once again, it's always a treat to have, this is like what, the third or fourth time that you've been on here, Greg?
Yeah, I think it's the third now, Rick.
The third. So yeah, I think it's the third. We're so happy to have Greg Cantwell from Texas with us, and Greg is the founder of Greg's Mission. It's a one-on-one brain cancer, any kind of cancer, but brain cancer specifically support. And Greg is a brain cancer survivor. He's going to give us his journey, which is incredible in and of itself. We're going to be talking about some different brain tumor trials that are out there, and we've got an action-packed show. But first, before we even get to that, Greg survived an arachnid attack yesterday, which was incredible. I was really fearing for his life on that also. He described it as big around the body as a quarter, and Greg doesn't even embellish things, so I'm thinking that this is like some sort of like southwestern, I don't know, he said it was a cross between a wolf spider and a tarantula, so I'm not even too sure what kind of species of spider this is. He said, and you correct me if I'm wrong, Greg, because as big around the body as a quarter and the diameter of a compact disc. Am I right?
Well, about a medium-sized compact disc, so it's a little bit smaller than a compact disc.
What's a medium-sized compact disc? I mean,
one of those small ones.
Okay, so that's like a tiny compact disc. So it's either a CD or it's not. And you know, we were on the phone yesterday, and so Greg and I talk fairly often, and we were doing some prep for the show, and so I'm stuck in traffic on the interstate. So I decided, well, it's a good time to give Greg a call. Greg is like in a panic, and I never hear this man in a panic. He's been through, ridiculous things, and he's like, Rick, I got to call you back. I've got this big spider. And I'm like, okay, that's fine. I'm afraid of spiders too. So, they're scary as heck. And so I was kind of fearing for his life. So tell us about the spider. Did you get him?
No, I did not. It ran across my dashboard while I was sitting at a red light, and the light turned green, and I tried to hit it, and I missed, and it went underneath the seat, and that's the story. Yeah, it's I don't like spiders. I don't know about you, Rick, but I despise spiders, and this one was big. And here in Texas, we have big spiders, and it's just something that I didn't want to deal with, so I pulled over in the Lowe's parking lot, and the people at Lowe's came out and checked it out for me and couldn't find it, and it's still in there somewhere.
That's really funny. I have to kill spiders at our house. Like my daughter is just she just freaks out, and my wife she'll kill them, but like she just like goes crazy on them and like chops at them and stuff like that. She'll whack them with like whatever is there, a fly swatter or 2x4, whatever's there. So we'll have the house destroyed. And I know she's listening, and my wife is extremely courageous, so she'll go after the spiders also. It's just it's great. And so you let your truck air out, and you're still not confident that spider is not there.
Correct.
Yeah.
Yeah, it's when we moved to Texas, we've had a couple incidents with one with a rattlesnake in our garage, all curled up in the corner, and now this really big spider. We've had spiders in the past, but this one is bigger than normal.
Yeah, I don't like snakes even more than spiders, so that would be bad. And I'm sure that I didn't make it any better by saying that more spiders probably crawled in while the doors were open, and that wasn't. I don't think that was the right thing to say. I thought at the time it was probably better, but I'm sure that I was wrong. But I mean, that's just me. But okay, enough of spiders. Welcome, Greg, back to the show. It's always fun to have you here, and we always have not only a lot of fun when Greg's here, but we always get a lot of information when Greg's here. Greg's been doing support and information and one-on-one brain cancer support for many, many years, and he's a 13 or 14-year brain cancer survivor, and he's going to tell us his journey coming up. And we're also going to be talking about a lot of these clinical trials that people may not know about, and we're all about giving information here at Brain Tumor Talks. So we're going to be talking, we're going to be touching on some of these kind of briefly about these different trials that they have for not only primary brain tumors, but tumors that metastasize. Correct, Greg?
Yes, that's correct.
Okay, very good. So why don't you share with everybody a little bit about you and your journey and Greg's mission with people who may not be aware, because we have new listeners all the time from all over the world.
Sure. Well, thanks for having me, Rick, again. So I was living in Hawaii, and I accepted a position with Northwest Airlines in Minneapolis, and the night I got to Minneapolis, I had a grand mal seizure, and this was back in 2004. I was rushed to the emergency room and given a CT scan and MRI and given the diagnosis of a brain tumor. They didn't know what it was at the time, but it was a mass in my brain. So I was scheduled for surgery a couple weeks later, and they found out that it was a glioblastoma multiforme, and I was given a year to live. And, that wasn't acceptable to me. My son was 8 months old at the time. I had to be here for him. I had to be here because there was a lot of stuff that I hadn't done. I was only 30. I'm 42 now, and I wanted to be here for him. And, I want to see him graduate from high school and do all the things that my dad wants his son to do. And so I was given 3 treatment options. One was just the standard of care, surgery, radiation, chemotherapy, and Timidar. The other one was not do anything and just live out the time that the doctor said I had left. And the third one was very aggressive, and it gave me the best chance at longevity. And longevity is what I was looking for. So I took that option, given the fact that I resigned myself to the fact that, hey, this may cause me to be sick for an entire year, but if that's what I need to do to make it through this and be here for him 10 years later, 20 years later, this is what I need to do. So I buckled down, which began to be the fight of my life, and I had surgery. Like I said, I had radiation, Timidar, and then after that, I did intraarterial carboplatin, where they go in through the femoral artery in your groin and thread a catheter up into your brain and release the chemotherapy right on the leftover cancer cells. Rick, I forgot to mention also, during surgery, I had the Gliadel wafers. These wafers are chemotherapy wafers. They dissolve over a 2.5-week period, and I had 5 of them implanted into the resected tumor site, the cavity. And then I did, in conjunction with the intraarterial carboplatin, I did Cytoxan and etoposide through a port which they put in my chest. These treatments were done in the hospital once a month, 2 nights and 3 days, and I did 12 cycles of that. And after I finished that, I haven't done chemotherapy since February of 2006. And And God willing, I haven't had a recurrence yet. And yeah, I thank God every day that I'm here, because nobody's guaranteed tomorrow. And
Well, for sure.
I just live life to its fullest and do the things that I want to do, because it's important that you create memories for your loved ones.
Yeah, amen, brother.
Regardless of if you have any illness or anything like that, because like I said, you don't know when your last day is.
That's entirely true. I fully endorse that statement. And one of the things that we've talked about is the wafers that you had in the brain, and how incredible is that? And that is a treatment that so many people don't have. And is that something that we want to see more of?
I would love to have that be part of the standard of care. The problem is that it's the lack of information. Patients aren't given that information prior to going into surgery. The neurosurgeon doesn't bring it up most of the time. And I would love to see the neurosurgeon give the patient the opportunity to say yes or no, I want the wafer. I mean, there are risks involved. But, in my opinion, the benefit far outweighed the risk for me.
Well, I mean, your risk when you have brain cancer is you're going to die. So I mean,
right?
What you've got the scales, and they tip either way. It seems to me that they're fairly even when you look at each individual case, of course, but in your case, of course, and we always say all the time that statistics are statistics, and the numbers don't apply to everybody. But the 5-year survival rate, they gave you a year, but less than 2 people out of 10 make it 5 years with a GBM.
Yeah.
And so the risky, okay, it's something that should be offered, right?
Yes, it should, and it's the patient's life. So let them make the decision whether or not they want them. All doctors, all neurosurgeons don't put them in. So if you want them, and you've got to advocate for yourself, and possibly find another neurosurgeon who does have them available to you, and we'll put them in.
Yeah, that's the thing, and there's not enough. There's people like yourself that give that information, but there's not enough resources out there that when people are diagnosed with brain tumors and brain cancers, and of course there's you, and then there's wonderful organizations, the National Brain Tumor Society, the American Brain Tumor Association, and so many others that give so much information, but there's not enough places to go to really get the information that you need when you want to go elsewhere for treatment, right?
That's correct. Yeah, when you're diagnosed, the emergent situation is getting that tumor out, and you're not given a piece of paper with treatment options or anything like that right off the bat. And that's where I would like to see the information being given, is to these are the treatments that you can have during surgery. Because once surgery happens, you're essentially behind the ball in that, and they're not going to do another surgery unless it recurs. But we want to be proactive and get everything up front so that it gives us the best chance of it not recurring.
Right, and everything that we seem to be doing, and everything seems to be reactive, not really proactive. And
that's right, and that's where I was lucky. I mean, like I said, I just landed in Minneapolis. That night, I had a grand mal seizure. Didn't know anybody. I was just, by the grace of God, brought to a hospital where they had the proactive neurosurgeon and neuro-oncologist. And it's not a hospital that you would think of even for cancer. I mean, it was really in the ghetto of Minneapolis. The hospital's name was Abbott Northwestern. And just, like I said, by the grace of God, the proactive neurosurgeon and neuro-oncologist work really closely together. And I was able to receive that proactive treatment. And who knows what would have happened if I wasn't afforded that opportunity right from the beginning.
Right. Yeah. Exactly. And that kind of leads us and segues us to where you are now with Greg's mission.
Yeah. So I started doing one-on-one brain tumor work in 2008, and I started my nonprofit in 2012 called Greg's Mission. And for those of you who haven't been to the website, it's gregsmission.org. And I provide one-on-one brain cancer support, brain tumor support to patients suffering from all types of tumors. And I also volunteer at major cancer centers, and they refer me their brain tumor patients to mentor and help through the process. It's one thing to call an organization and to be on the phone with a social worker or a nurse who's flipping through a book. When you tell them that, hey, you have a GBM, for example, and they flip through the book and there's a list of questions that they need to ask. I've been there. I've had a craniotomy, I've had radiation, I've had chemotherapy. That's really unique to Greg's Mission. I don't hire people to talk on my behalf. I'm the one who answers the phone. I'm the one who returns emails. So I've been in your shoes.
And how many people do you think that you've helped one-on-one over the years? Just a estimation.
Over the past 8 years, probably 2,700. A little bit more, maybe.
It's amazing.
I mean, I get about 10 to 13 new patients every week.
And do they just find you through the website, or is there other organizations that kind of funnel them to you?
Well, I volunteer with Immerman Angels. Immerman Angels sends people to me. I volunteer at MD Anderson. MD Anderson sends patients to me. I volunteer at Cleveland Clinic. Cleveland Clinic sends patients to me. And I also volunteer at Children's Brain Tumor Foundation in New York City, as well as National Brain Tumor Society.
Right.
So in addition to people just finding my website by searching Google or going on Facebook and typing in GBM and stuff like that, I volunteer at wherever I can because I want to help as many people as I can and give as many people the education so that they can make an informed decision on what's best for them and their family. I make sure that everybody has all the treatment options with a link to each treatment option so they can do their own research and come to their own conclusion as to what's best for them and how aggressive they want to be. Everybody's different.
Yeah.
So, I don't make any assumptions, and I just give them the information, and I'm there for them along the way, and they make the decision, and I'm there to part of their team and to advocate for them too.
Well, that's a beautiful thing, and as a matter of fact, so the listeners know, for the years that I've been doing, support and things like that, I have guided a handful of GBM patients to Greg because he's the best, and hands down, bar none. And it's true, and not because he's on the phone with me. It's absolutely true. And Greg is you and I have become pretty good friends, and we're actually going to hopefully meet at some point this year because a hospital here in Pennsylvania is actually doing something with you, right?
Yes, yeah. My old neuro-oncologist in Iowa has accepted a position or has been down at a university hospital down there in Pennsylvania, and I'm going to be working closely with him and his patients. So yes, we are definitely going to meet in person finally and sit down and have a cup of coffee, Rick.
Yeah, coffee, exactly. And that's gonna, yeah, and that's gonna be down, and that's in Hershey, right?
Correct.
Yeah, so
Correct.
that's gonna be fantastic. So, Greg is he's got all the credibility, and when he comes onto the show, like I said, we always get so much valuable information. And now we're gonna really talk about the meat and potatoes of what the show is about today, and it is the neuro-oncology clinical trials. And Greg put together a pretty good list of some brain tumor for primary and for the ones that metastasize, some trials that are out there that you may not be aware of. And we're going to go over those and a little bit of facts on them. And we don't have a lot of facts on them because they are trials. And Greg, let's talk about what a trial is first off before we even go any further, okay? So, talk about what trials are and how they work, okay?
Well, a trial is just that, a trial. It's not. It hasn't been accepted by the FDA yet, and it hasn't been proven. And trials are necessary to get drugs through the FDA, through phase 1, phase 2, and phase 3 of the trial process. So we definitely need people to sign up for trials because we still only have 4 treatment options for brain tumors. Clinical trials are important to get drugs to the market in order for it to be available to everyone. It's people have their own opinion on trials and so on and so forth, but one thing that I do want to mention is that if you are interested in a clinical trial that you may not qualify for, and that happens to more than enough of us, where we want to be a part of a clinical trial because we need another option and we're running out of options, and if you do want to and feel strongly about being a part of a clinical trial and you don't qualify for it, you can use the term compassionate use and tell your doctor that you want to be part of the clinical trial due to compassionate use. And that term allows the doctor to do some extra paperwork and submit it to the pharmaceutical company in hopes of getting you that drug because there's no other option. And most of the time that does happen. It's not guaranteed, but that is a way to circumvent the trial protocols and hopefully be able to get you that drug and, increase your longevity.
I had no idea about that. That's amazing. That's good information, and I know that that's going to be useful to some of our listeners out there. The one clinical trial that most people are familiar with because it got so much press was on the 60 Minute show with the polio virus that was featured. And that's really important, not because of what it is, but because it brought a lot of what's going on in trials with brain cancer to the forefront. And these also are very important. And I was looking through them, and there's different phases that are here in these trials, and so that just shows that they've been going on for quite a little while. When I see phase 3 here, phase 2, so these aren't just brand new trials, and these are also not only for the primary brain tumors but for the brain metastases. And there's also we're going to talk about the other studies here that that's a collaboration with NASA on here too, I see. So that's pretty interesting. So, do you want to start us off here?
Sure. So there's a center in California, John Wayne Cancer Institute, in conjunction with the Pacific Neuroscience Institute, that has a number of trials which are ongoing for newly diagnosed patients with GBM, patients with recurrent or progressive brain cancer, and recurrent glioblastoma multiforme. And the important thing to take away from this is that the John Wayne Cancer Institute has many options which other centers may or will not have for you. That the doctor over there, Dr. Santosh Kusari, will find a biomarker-based treatment for you as a standard of care or in the clinical trial setting. So he will look at your biomarkers and he will come up with something personalized, and that's the key: personalized medicine. Like you said, Rick, trials go on for years. I mean, it literally takes years to go through, all the way up to phase 3, and then hopefully within, 5 to 10 years, it'll reach the FDA. And there needs to be an accelerated process to getting trials to the FDA and passed. People wait too long for drugs. Some states don't have access to these drugs, and people's lives are at stake.
And this is why I just want to interject a little bit that this is why so many people, and you've seen it, and I know you have because I've seen it, that people go internationally to get these drugs and these treatments also because the process here is just so long, and in other countries it's quicker. It doesn't mean that the drugs are necessarily better or that they're more effective, but it's a faster process.
Yeah, that's true. Mexico and Europe, Germany, for example, people are going over there, to get treatments that aren't approved by the FDA, or they don't have access to we don't have access to them all here, and that's unfortunate because the United States should have access to all the big treatments out there, whether it's a clinical trial or a proven treatment, and it's just not the case.
Nope.
I do want to say that all the current information regarding trials at John Wayne Cancer Institute can be found on the Pacific Neuroscience Institute.org website. And once you're on that website, you can go under the tabs brain tumor, then clinical trials, and current trials. So they continuously update their site every 2 weeks with new clinical trials that they're putting out. For all the three, the GBM patients, recurrent GBM patients, and other brain tumor diagnoses as well.
And we're going to post this up on the Brain Tumor Talk Worldwide Radio Show Facebook page also, if people need to access this. So this information is going to be posted up as well if you need to reference it too. Okay.
Yeah, good. So there's one more clinical trial which I'm pretty excited about, and it works with MGMT biomarkers. So it has to do with the methylation of the tumor. And those of you who don't know what MGMT is a protein that repairs errors in the DNA. When the gene encoding MGMT is silenced by methylation, chemotherapy may be more effective because cancer cells cannot repair cellular damage. So testing for the MGMT promoter, gene promoter, has been used to identify whether or not a patient could benefit from the chemotherapy drug temozolomide. And that's the oral chemotherapy that patients take during radiation and for the standard of care, Temodar. So this MGMT test is extremely important for the efficacy of if that drug is going to react positively or negatively with your tumor. So if your tumor comes back MGMT unmethylated, you have much less of a chance of the Temodar actually working. So the idea of this is to find another drug for the unmethylated population. 60% of the people with, for example, GBM diagnoses are unmethylated. And currently, there is no treatment for the unmethylated population. They just go through the standard of care like every other GBM patient. Well, there's a new trial, not necessarily, well, it's not new, it's in phase 2 right now, and it's done in conjunction with Del Mar Pharmaceuticals as well as MD Anderson here in Houston, Texas. It's called VAL-083. It's for patients MGMT unmethylated and Avastin naive and recurrent glioblastoma multiforme. So there's a number of with every trial that's out there. There's a number of eligibility criteria. I'm not going to go through them all because I don't have time for that. But it's all on, and I'm going to give you the site to go on, and I post it probably twice a week on my Facebook page too about these trials. I lost my train of thought. Sorry, I have a brain tumor.
We were talking about the trial from the Del Mar phase 2.
Yeah, so
the Val 083.
Yeah, and that to me is the next. This is where it's at right now for the unmethylated population. And like I said, they are currently enrolling into the trial, phase 2 trial. And to find out whether you're eligible for this trial, you can go to, like I said, Greg's Mission's Facebook page, or email me at greg.cantwell@gregsmission.org, and I'll email you the link that you can go on and find out more information from Del Mar and MD Anderson in regards to that trial. Other clinical trials can be found at clinicaltrials.gov, and it's like I said, I can't stress enough that trials bring drugs to market, bring effective drugs to market, and it's extremely important that people sign up for these, especially when there isn't really anything to lose. And this VAL-083 has a potential to help over 6,000 patients in the United States alone. And that seems small compared to other cancers, and it is small, but it's 6,000 people's lives. And Del Mar Pharmaceuticals and MD Anderson have taken that on, and hopefully within a year, we should be hopefully in phase 3 and approved, because that's where we need to get to. We need more drugs approved, and it takes voices to make the FDA realize that, hey, we're out here and we don't have any options. So let's fast track some of these drugs and let's bring them to market.
And we talked about 6,000 people, but when you look at the bigger picture, and it's not just 6,000 people, you're looking at something bigger than that. You're looking at something that has 4 new drugs. Is it 4 in the last 30 years, or is it less than that?
4 in 30 years.
So 4 in 30 years, which is unacceptable, and it's absolutely ridiculous. You're looking at, especially for GBM, you're looking at a mortality rate that is just horrifying. You're looking at you look at all brain tumors, which there's 120 different types. So you're looking at even, and we all know how I hate the word benign, but the non-malignant types of brain tumors, which are just as dangerous and deadly. And so there's no silver bullet for any of these, and these trials are not silver bullets. And when Greg and I were talking before we came on air, and these are not silver bullets, but these are a part of the way that we fight it, and that is bring these drugs to market, and he's right. There's nothing to lose, and the what is it? Compassionate care. What was it?
Yep, compassionate use.
Compassionate use, and that's amazing. I had no idea about that, and like you said, it's just a little bit of extra paperwork for your doctor, and it'll hopefully extend your life a little bit. But there's no cure, and we're talking 6,000 people, but you're talking 700,000 people in the United States alone with the diagnosis of a primary brain tumor, and those that metastasize are even greater amounts. And we've got trials right here that we're going to be talking about briefly, because we're running out of time, because this happens every time that Greg's on the show. And that for the brain metastases. And there's also, when you're talking about the ones that metastasize to the brain, there's the blood-brain barrier, and we're going to have a show that just talks about that, because amazing things have been done with that, right? And Dana-Farber and other amazing places are, they're breaking that blood-brain barrier where they're being able to be treated, right?
Yeah, that's correct. In the past, there hasn't been drugs that would break the blood-brain barrier, and that's what you need when you're fighting a brain tumor. You need drugs and other medications that break the blood-brain barrier to be effective. And they're coming out with them now. They're coming out with different ways to break the blood-brain barrier, not just with medication, with surgeries and stuff like that, with putting in shunts and stuff like that. Just much more effective ways to treat brain tumors. And now we just need to come up with drugs to go along with that.
Absolutely. And this is why we do what we do. And so let's talk now, before we run completely out of time, some of these primary brain tumor trials that are going on. Okay, do you want to start, or would you like me to?
Go ahead. You can start.
Okay, so I'm going to read some of these off. They're going to mean absolutely nothing. But so the name of these, it's ABVRTOG. It's the study for subjects with newly diagnosed glioblastoma. It's in a phase 1. And this one is also, we've got a phase 3 for the immunocellular. It's a phase 3 randomized double-blind controlled study with maintenance temozolol. I don't know how to say that. And I'm not a scientist. I just play one on the radio and TV. In newly diagnosed glioblastoma following resection and TMZ chemoradiotherapy. So that's pretty good if it's in the phase 3 of the trial. Then there's one.
Yeah, that one.
Go ahead.
That one's done at John Wayne Cancer Institute, and it's like Rick said, it is phase 3. So it is almost done with its effectiveness testing, and it's in newly diagnosed patients. So those who don't want to do the standard of care can enroll in something like this and get the immunology portion of it as well as the temozolomide, which is Temodar, the oral chemotherapy that I talked about before. And this is done in following the resection, so following surgery, and the radiation with temozolomide together. So this would be an ideal situation if you want to do something more aggressive, and it's very proactive. So that's definitely one to look into. There's a number of other companies, pharmaceutical companies that have other trials out there. Obviously, Netsivus, Inspire Therapeutics, Orbis Therapeutics,
Triphase, yeah.
There's everybody has stake in the game.
Yeah, they do. Eli Lilly is in there, and they're a big time drug company. So there's yeah. I mean, we're not here to shill for any drug companies. I mean, they're all these big drug companies have a stake in this for sure, and they're doing their due diligence for research on it as well. We're going to touch on just a couple of them. These phase 2 and phase 3s. There's a phase 2 for a single agent marizoba of progressive or recurrent grade 4 malignant glioma. So that's a pretty good one right there. Now we're going to talk about the brain, the ones that metastasize to the brain, and there's a lot of phase 1 and phase 2s with that because they're tougher, and I think it's because there's so many different cancers that go there, but the ones that go most of the time to the brain or the lung and the breast. But there's so much that's being done now is brain barrier and things like that they're really doing a lot of research on these things. And there's let's see, Eli Lilly is doing a phase 2 study with patients with brain metastases secondary to hormone receptors positive to breast cancer, non-small cell lung cancer, or melanoma. And that's really important. I just had a coworker and friend who I'd worked with for about a decade, and he passed away from a melanoma in his throat, and it spread to his brain, and he had no fewer than a dozen brain tumors, and that was pretty awful. And he was my age, which is just terrible. So out of nowhere, which is really crazy. There's one that I saw here. Subjects with non-small cell lung cancer activating mutation, prior treatment with something called tyrosine kinase inhibitor. Do you know anything about that?
I don't know anything about that one.
It's with brain metastases. There's so much being done with on the brain metastasizing side that I'm not really familiar with. I haven't. I'm more familiar with the primary brain tumors, and so that's the ones that metastasize is kind of new for me.
They're tricky.
Yeah, they're really tricky
because their genetic makeup is all different, and so it's going to take different types of chemotherapies and medications in combination with the regular brain cancer chemotherapies to fight these. The primary brain tumor starts in the brain and it doesn't go down. Any type of cancer in the body can go up to the brain. So it's tricky when it goes up.
Yeah, they start in the brain, they stay in the brain, they don't go down. So that's pretty crazy. Now, the thing that I was talking about with NASA, did you want to touch on that? It's okay, because I found it really interesting. I was hoping that you'd let me do it. So So the National Space Biomedical Research Institute has been working with NASA with the astronauts, and they were conducting a feasibility study to determine the optimal thigh cuff design for patients with to do the central nervous system chemotherapies to see about how it happens with swelling. Basically on intracranial pressure, and so they tested it on it's going to be a testing device that's going to prevent visual impairment and intracranial pressure, which is VIP. They've got to go and have letters to do everything. It's a syndrome in astronauts involved in long-duration space flights on the International Space Station. Now, the current study explores a number of psychological variables that may impact vision changes that have been reported in more than half of the American astronauts after long-duration space flights. So that's pretty interesting. So all of this kind of kind of intertwines and parlays into what the brain can do even in space. So that's kind of crazy.
Yeah, it sure is.
Yeah.
Sure is.
So that's really the bottom line is that these trials are very, very important, and what you do is very important. And we're at a time, unbelievably, I can't even believe it. That's about our show.
Can I say, Rick? Can
Go
I say
ahead.
one more thing?
Yeah, absolutely.
Just to let everybody know that the trials that we talked about today, these aren't the only trials that are out there. If you want to find other trials, go to clinicaltrials.gov. All the trials that are available in the United States are on that website. And you can break them out to brain cancer, breast cancer, colon cancer, whatever your diagnosis is. So I just wanted to give you that information. And don't forget the term compassionate use.
We're gonna include all that. That's very important information. The two things that you just said, and we're gonna include all that information. It's on your website, but we're going to include it also on the Worldwide Radio Show Facebook page. Also, that is again. This was just a phenomenally informative show, and Greg, always a pleasure to have you here. What's next for Greg?
Thank you, Rick.
What do you got going on? What's the fundraising going on for Greg's Mission this summer? Do you have baseball games going on?
No, not this summer. I don't. Like I said, we just moved to Texas, so I'm starting my network here. I was just on. I just did a spot on Good Day Austin on Fox Channel 7, live in the morning, and looking to get into other media outlets to let people know that I'm here. I'm in Texas now, and to let people know that they can reach out. Nobody knows because of the HIPAA regulation. So we have to, do our own advocacy to let people know that there is somebody in your backyard now. I help people all over the country and world, but I'm in Texas now. So, I want the people in Texas to know that, hey, if they want somebody to go to their doctor's appointments with them, I'm available.
Beautiful, excellent. And when you were on the Good Morning Austin show, it was great. That was a phenomenal clip that you put up on the internet, and it was great to see the family that you helped. You want to talk a little bit about that before we wrap it up?
Sure. Yeah. The gentleman that was on has a son who was diagnosed with a GBM. I helped him very early on after his diagnosis, and he's doing great. I'm happy to say, happy to report. And we've become very good friends, not just his son, but with the family. And that happens quite a bit, where I become very good friends with the family and their loved one who is a patient. I'm honored to become friends with them and help them and help anybody who needs the help.
That is great, and it was great to see you do your thing right there on TV, and you're a phenomenal guy, and again, one of my personal heroes, and we thank you so much for your time and your talents and for being here with us once again, Greg. Thanks again.
Thank you, Rick, and thank you for Brain Tumor Talk too.
You
Couldn't have
got
done
it.
it without you.
Well, I appreciate it. Thank you so much. Greg Cantwell from Texas, and he is the founder of Greg's Mission. They're a one-on-one cancer support group. He does cancer. He's helped one-on-one 2,800 people at least, and he is a glioblastoma multiform survivor for over 12 years, and Greg is an amazing individual. Greg Cantwell, thank you so much for being here. This is Brain Tumor Talk. Thank you. Brain Tumor Talk, Worldwide Radio Show, right here on 90.3 WESS.